Hello everyone, I'm Deborah Dean Whitaker with CMS, and unlike many of the people who you have heard from today, I don't have any clinical experience. I am a survey researcher, and I'm going to be talking to you from that perspective. Let's see if I can get this done right. Is this it? Our objectives of our presentation today are fourfold. First, I want to give a brief description of the CAHPS Hospice Survey. You can spend hours talking about it, but I'm not going to do that. I'll just give you the top line. I want to talk about its place in the Hospice Quality Reporting Program, of which it is one component, how to comply with the CAHPS Hospice Survey, what happens if you don't, and then what exemptions are available. Can everyone hear me? It sounds a little funny out here. Okay. Let's start by talking about the CAHPS Hospice Survey. The CAHPS Hospice Survey is part of a family of surveys known as CAHPS, C-A-H-P-S, and it stands for Consumer Assessment of Healthcare Providers and Systems. There are several of these surveys. One of the more famous is the CAHPS Hospital Survey, and many of you may be familiar with the CAHPS Home Health Survey. Results from both of these surveys are currently available on the Medicare.gov website. The CAHPS Hospice Survey is a successor to a survey many of you may already be familiar with, the Family Evaluation of Hospice Care, or the FEC. Some of the people who created the FEC were also intimately involved in the development of hospice CAHPS. Indeed, one of the major differences between the surveys is that the CAHPS survey has a more detailed and strict requirement for survey administration. We have, in fact, a book I brought with me, it's that thick, with instructions on survey administration. Now, the reason we're doing this is to try to ensure that all vendors do the survey in the same way. And the reason we want them to do that is that if they do the survey differently, the results might differ on that basis alone, not on the basis of what the hospice was doing. So we want everybody to do the survey the same way, and then when we publish our data, which we are hoping to do on the website, the data will be comparable across the providers. The Hospice CAHPS Survey has two major goals. First is to enable CMS to publicly report about hospice decedent and caregiver experiences, and we do plan to put that on the Medicare.gov website, and we talk about decedent, that's the patient, / the caregiver. We're treating them as a pair. And so public reporting is really one of our major goals. Another, however, is quality improvement. We hope the CAHPS Hospice Survey will be something you can use for quality improvement internally to your own hospice, to set benchmarks and to undertake quality improvement programs. The survey is also something that CMS can use to kind of track quality with respect to hospices in general. So it's just another source of data, not the same as his for CMS. Okay. This slide shows some details about the CAHPS Hospice Survey. It has 47 questions on it. Not all of the respondents have to answer all 47 questions. There are some things we call skips, where if the thing isn't relevant, they just don't answer that question. It is slightly shorter than the FEHC, which was 54 items, but in general, they're about comparable. The survey is given to the primary informal caregiver of a person who died while under hospice care. So we are not interviewing the patient, we are interviewing the caregiver, typically a family member, sometimes a close friend. Now, how do we find this person? We ask you to tell us who they are. We are asking you for their name, their contact information, and some other administrative data. So you can see that the hospices, as hospices, you guys play a critical role in this survey from the very beginning. We cannot do the survey without a sample. We don't have a sample if we don't have caregiver names and contact information. The survey can be given in any one of three modes. You can do a mail survey, you could do a telephone survey, or you could do what we call a mixed mode survey. And in this case, what we mean is you would start out by doing a mail survey, and then you follow up with a phone call to people who have not responded to the mail survey. Of these three modes, it is typically the case that the cheapest is mail. We do not currently have a web-based or email survey. We are doing some investigation of this, but we are not ready to offer that yet. So what we have now are just these three modes. For the telephone survey, we have a version that is available in English and Spanish. So you would be able to do a phone survey in Spanish or in English if you wish to do so. The mail survey, however, has more languages. The mail survey is available in English and 8 other languages, including Spanish, traditional Chinese, simplified Chinese, Russian, Portuguese, Vietnamese, Polish, and Korean. We are always in the market for requests for additional languages. And if you have a need, please do contact us and let us know of it. Right now, what we're trying to do is focus on the needs that have most impact in terms of the largest number of hospices and the largest number of people. But we are aware that there are some geographic concentrations where hospices need a specific language because of a demographic concentration in that area. Please make sure that you send us that, and if you've sent it to us once and we didn't do yours, send it again, because every year we add to it, and we do want to try to reach everybody. Let's see. Okay. This slide is called Topics on the CAHPS Hospice Survey, and indeed it does refer to topics on the survey, but it also refers to the measures that we intend to use on Medicare.gov. The first 6 of these measures are what we call composite measures, which means they are composed of many individual questions from the survey averaged together. Let me give an example. The first measure there, the first topic, if you will, is hospice team communications. That is actually composed of 6 different questions on the survey. One of those questions asks about how well the caregiver could understand the explanations that the hospice team provided. Another question asks about how well the hospice staff listens, in the opinion of the caregiver. There are also questions about how well the hospice staff kept the caregiver informed. Okay? Now, these are various aspects of communications, and so what we try to do is bring them together, create an average score, and that is what the composite measure reflects. All of the composite members have multiple items in the measure. Now, the last 2 items listed there are different. They are single item questions. There is an opportunity for the caregiver to rate the hospice care provided, and an opportunity for the caregiver to say whether or not they would recommend the hospice. You may notice that these things are not about satisfaction. Sometimes the CAHPS survey is called a satisfaction survey. We actually never ask people how satisfied they are. We ask what happened and how did you evaluate it. Now, the Hospice CAHPS survey data collection doesn't begin immediately. If somebody dies in January, they will not be contacted to do the survey for at least 2 months, which means they wouldn't be contacted before April. The reason we do this is we want to show some sensitivity to the caregiver. After all, this is a major event. Family member, a close friend has died. So we decided to lag it a little before we ask them to comment. At the same time, we don't want to wait so long that they have forgotten what went on. So at this point, we are doing a 2-month delay. Data collection occurs for 42 days, and it is followed by data submission to the Hospice CAHPS data warehouse. The next data submission deadline to the Hospice CAHPS data warehouse is February 8th. However, don't worry, you as hospices don't submit the data. Do not. Your vendor submits the data for you. However, it is a good idea to be aware of these data submission dates, and this probably will become, the reasons why will become more obvious later. But in general, your data submission deadlines are the second Wednesday of the following months: February, May, August, and November. That is the second Wednesday, February, May, August, and November. Now, I'll just briefly say that as hospices, you are responsible for making sure your vendor is sending in the data on time. So if you know when the deadlines are, it makes it easier for you to get in touch with the vendor and make sure they're ready or have submitted your data. Go ahead and press your button for that. Do I go ahead and press the button again when people are done? Thank you. Everybody finished or not? Try it again. Oh, 2 is the right answer. Thank you very much. Okay. Go to the next one here. Oh, thank you. I didn't know that was. Thank you very much. Do I sign? Okay. Survey requirements. All Medicare certified hospices are supposed to participate in the CAHPS Hospice Survey in order to fulfill their full APU. The patients involved can be from any payer source. Yes. I know, and I don't know what to do about that. Should I hold on to it? Back off. Okay. Is that better? I'm sorry? All right, real fine. Let me know. I'm sorry. I thought I heard something funny. Okay, if you are a Medicare certified hospice, you must participate unless you're exempt. I'll explain that later in order to get your full APU. Your hospice, your provider number is what we use to track compliance. So it is very important that you give us the right provider number. You could end up, if you give us the wrong provider number, you don't get credit for the data, you end up with a reduction. It's a mess. Be very careful. We haven't had this problem much with hospice, but with other CAHPS surveys, we've had problems that the wrong provider number is submitted. Please be very careful to make sure that your provider number is correct when you send it. Okay, there are 2 allowable exemptions from the Hospice CAHPS survey, and they're quite different. One of them is size, and the other is newness. Let me give a little bit more discussion on each of these. The criterion for the size exemption is that your hospice must have served fewer than 50 survey-eligible decedents and caregivers in the reference year. Is that clear to everybody? Okay, here's what it really means. You count the number of survey-eligible people you had last year. If you have fewer than 50, then you should go ahead and apply for the size exemption. That's it. The reference year simply means the year before. I think we have an example on the next slide. Yeah. So if you served fewer than 50 decedent's caregivers, and each pair is counted once, during the year from January 1st through December 31st, 2015, you could have applied for the size exemption in 2016. This year, you would count your decedents and caregivers for 2016 in order to apply for the 2017 exemption. Let me make just a brief comment that we do check. Just to let you know. We believe you, but we also check. All right, oh, I love this down here. Okay, important piece of information. This is only good for a year. Only good for 1 year. The reason is this: hospices can change size. All providers can change size. You can see that some of them grow rapidly. So they start out small, they start out eligible, but 2 years later they aren't. So we ask you to reapply every year for which you think you are exempt. You don't just apply once and assume it continues. To apply for the exemption, you go to the survey website. That is shown here at the final link, www.hospicecahpssurvey.org. This is a very useful website. It's mostly really for the vendors, but you can find information that you can use here as well. There is news, there are the manuals, there's the list of vendors. So this is a very useful thing, and the exemption for size form can be filled out and submitted from this website. Now let's talk about the exemption for Newness. Newness is based on how recently you got your CCN, also known as your provider number. And this criterion for CAHPS is not the same as it is for HIS. For CAHPS, you must have received your CCN on or after the first day of the performance year for the Hospice CAHPS survey. So, example. Oh, I didn't have the example. Well, let me give you an example. If you got your CCN January 1st of 2017, you are too new to participate in the Hospice CAHPS survey. If you received your CCN, or will receive it, in October of 2017, you are too new to participate in the Hospice CAHPS survey for 2017. It's a one-time exemption. It is awarded by CMS. There is no form. You don't need to fill anything out. We will give you this exemption. But it is a one-time exemption only. So let's ask this question. Is the participation exemption for size available only once? True or false? Whoops, I must have pushed it too hard. It is false. The exemption for size can go year to year, and if you remain small and you keep applying, you can keep receiving it. It is only the Newness exemption that is one time only. And finally, for more information, we have 3 bullets here. This first one has to do with the survey website. We have once again given you that link. The second one is for the technical assistance team, and don't hesitate to call them or email them. It is very important to get to know them and feel comfortable calling them. This is particularly true if you decide to switch vendors, for example, or you have a problem. Call them up, let them know. They will really try to respond to you. And then the third is our email address for the Hospice CAHPS survey here at CMS. And please don't hesitate to use that either. We will be happy to respond to you. So thank you very much, and if there are any questions, I'd be happy to respond. I think I did too. I can't see so well from here. Do you know which ones were missed? Do you know? No, you don't. The vendor. Okay, let me tell you about that. I can tell you about the vendor requirements. We have a thing on the website that gives a list of approved vendors. There are 26 of them. And they cover all kinds of things. They're new, they're old, they're big, they're small, all kinds of vendors. You need to pick one of the approved vendors. We recommend, we don't require, we can't do this, but we do recommend that you call and talk to more than one of them and get a sense of what they're charging, what services they provide. Do you feel you could work well with them? So you do need to use one of the approved vendors, but you can pick whatever you want. In general, your charges will be lower for a mail survey, although vendors also offer additional reports and other services that you may decide you do want or that you don't want. So, sorry I missed that. I thought something was wrong. I couldn't see quite the thing to check. Yes?
Thank you very much. You did a great performance or a great presentation. One question that we've encountered recently is we have caregivers who are listed on admission as the primary caregiver, but through the course of the patient's stay with us, sometimes that person becomes less important to fill out the survey because duties might change. Would you suggest that we actually change our submission of the primary caregiver in order for the survey to be targeted to the correct person?
That's a very interesting question, and we've had this question in our minds and before. Generally speaking, we need to have consistency. It's very important in survey research to be consistent. And so we say, you tell us who the primary caregiver is, and that's who we're going to talk to. But you notice who's deciding who the primary caregiver is? You. We are aware that sometimes the primary caregiver and the person who knows the most are not the same thing. But if you guys have listed person A as the primary caregiver and given us that name, that's the name that we use. But you get to decide if in your opinion, the primary caregiver is something else. We don't really have a policy on that, but it is the case that you guys make the determination who you're going to give to us. Is that responsive? Are there other questions?
What do you do in the case that there really is no primary caregiver? In the, like, say, a guardian of the state, where a lawyer may have signed consent forms for the patient, there really is no one involved? If
there is no primary caregiver, then we cannot survey them, and we just simply don't include them. They're not eligible. You have to have a primary caregiver. The other thing is the primary caregiver has to be in the United States. The primary caregiver has to be an adult. And so they don't have to be in the United States. They have to have an American address. There's a list in the manual, which can be found on the website, as to who is eligible for the survey. And if you fall out on any of these, they're just simply ineligible.
My administrative assistant is getting letters back from, I think it's probably from whoever's submitting for us, saying the numbers don't jive, you're off by one number. So I don't know if it's maybe the vendor who's submitting for us isn't aware of how to calculate that.
Maybe we should talk about this offline. It is true that we do check things and that you have certain numbers of people and then the vendor is checking back and forth and we're checking the vendor, and we may be coming back to you for that reason, but let's talk offline if you don't mind.
I have one. What about the scenario where an address of a caregiver changes between the two mailings, the double mailings?
What we ask the vendors to do is to mail it in such a way as they're informed of the change. And so then the second address would be used if they follow protocol. And by the way, we visit them to see if they follow protocol. So that should be taken care of.
When you begin measuring for getting hospice care training, will there be a focus on that aspect in the home? Will the setting affect the rating?
Right now, we are planning on simply reporting it for all settings. But we are aware that the home setting is where it's most relevant. And there are internal discussions here about whether or not we need to change how we handle that. But right now, we are constructing our variables using any answers, although home certainly dominates.
If I could just advocate for the home setting, because that's where the real instruction occurs, and that's where a primary caregiver would be able to realistically and accurately report on that measure.
Right. Our original thought on this was when we did our technical expert panel, people were saying, well, a certain amount of training might be useful to a caregiver who is not in the home, but the caregiver is visiting at the nursing home on a routine basis, things like that. But it is an issue we're considering now. That's all. Thank you very much.